So the next speaker will be Dr. Kristian Jensen from Denmark, Copenhagen, Denmark. And yeah, I'll give the floor to you. We'll have the questions at the end of all the speakers. And please put your questions in the chat, or you can also walk up to the microphone and, yeah, in the room.
Thank you. So I'm a doctor, and I have nothing to disclose apart from an appreciation to Laura and Myresh for organizing this. So when a Kevin presents to me with depressed mood, of course the thought is this depression or is it something else? Because there are many disorders that present with low mood. So it can be masquerading other disorders or an underlying or comorbid disorder. And there are a lot of shared features among the different psychiatric disorders that we need to take into account. And one of the common shared symptoms is actually anxiety. So this is a classic example of the critique of that it's just one, that there's not that much differentiation between the different disorders because they have so many shared features. But I think it's worth appreciating that, for example, anxiety has many different qualities to it across the different disorders. But nonetheless, the different disorders, including depression, because it's so common, is very heterogeneous. Of course, it has core features that we use to define the disorder and associated symptoms, and we can calculate a lot of different symptom combinations from this. But once the patient becomes very, very severe, they accumulate so many different symptoms that the heterogeneity actually is reduced. And when you look at the symptoms that occur, or the symptom combinations in the wild, so to say, well, then it's not random. Only half of these combinations actually occur. Nonetheless, we have to maintain a focus on the heterogeneity and its relation to normativity, because this and the other psychiatric disorders are very heterogeneous in their presentation, but also the factors that influence their development, but also their outcomes, from the very genetic and biological to the psychosocial, and even the genetics at play isn't static either due to different methylation. So we have to look at this as a biopsychosocial perspective, but also on a life course perspective. Now this presents some challenges in depression when we have our patients, our Kevins at the start. We already have clinical features that tell us that this will go poorly. So we had red flags, for example, high levels of suicidality or childhood trauma, that give us a degree of certainty that this will take some time. But this doesn't really tell us what to do. So right now, many of the treatments are a one-size-fits-all model, and when that fails, then we start trying other things. So what we need to get more precise and effective treatments is to be able to predict the different treatment outcomes based on the many good treatment available options we have already. But we also need to take into account the different treatment combinations and sequences. We know, for example, exercise is really good for people, but it is not necessarily the first thing that a depressed patient that is severely depressed can do. They might need medication first. So we need to be able to predict the outcomes, but also the potential side effects of the different treatments we have available. So essentially, we need a compass telling us who benefits from what. And of course, when we meet a Kevin, we have an internal model as clinicians what normativity is. But we also need to understand the context that our patients are living in. So we do need, as mentioned, the time and context. So it's not a fast-reaching diagnosis. So to get more data and a very deep and thorough phenotyping, I spent most of my PhD acquiring a very large data set in Copenhagen. We're halfway there. We're trying to reach 800 first episode patients from the capital region of Denmark, where we follow them for 1.5 years, so we know everything that happens during their treatment course. With the Scandinavian registries, we also know what happened before they became depressed and what happens continuously during treatment. Before they initiate their treatment, we do deep phenotype with multimodal neuroimaging from EEG to MRI to PET, a lot of cognition and a lot of other sampling. The only thing we don't do is lumbar punctures and microbiome. But while I'm waiting for more data, I'm looking at the different ways we can potentially predict the benefits of our different drugs and treatments. And we already have different ways of assessing the brain's integrity using cognition, more molecular in the other end using PET, but not all of these are very scalable. And some of them we already have a lot of data on, so we have normative data available to us. And we need to think about what is actually implementable in the clinic. And this is where structural MRI and brain age predictions becomes very alluring, because it captures something that we in the clinic, of course, have a concept of. We see patients where we can clearly see that life has already taken its toll, and they appear in many ways older than expected. And sometimes when we see the MRI images, we are unsurprised about how it sometimes looks a bit older than it should. So using brain age, we can estimate a concept of how the brain should look, or how it looks compared to normative data, and estimate a gap, so to say, a chronological versus predicted brain age gap that may represent the cumulative neurobiological effects of depression and other disorders. And this may potentially indicate a need for certain treatments, so we can find specific biomarkers, but there are different biomarkers and models available right now, from the Enigma model to the PyMint to the BrainHR and several others that are developed and presented here. Now, one of the large ones is the Enigma model. So if you take a lot of patients with depression and compare them to healthy controls, you can observe that the patients, unsurprisingly, on average, appear older than expected, brain-wise. Now, this isn't that surprising, but what is also worthwhile is to see the very large distribution, or the wide distribution. There are a lot of patients that actually appear younger than expected, and we have to remember when looking at how old people they may look, that you can look old, but you can actually still be thriving. So I think it's more interesting, because we not only in depression, but also the other psychiatric disorders, see this average increased brain age gap, that it's perhaps more interesting to look within each disorder what this might represent and be meaningful for. So potentially this increased brain age gap might tell us that a patient needs a more biological treatment, compared to the patients that appear younger, who might benefit adequately from psychotherapy or a circuit-based intervention like TMS. So surprisingly, despite the abundance of brain age models, there aren't that many studies that have actually looked at it longitudinal in depression yet. There's this small Dutch study looking at elderly or geriatric patients with depression given ECT. You can see that using the BrainHR, they are slightly more old than expected on average. But this was not associated with the benefit of ECT treatment. Now, this to me doesn't surprise me. I'm not disillusioned by this, because we have to remember that the patients that are given ECT are highly selected. Because it's still a controversial treatment, we only give it to the ones where we have high certainty that they will actually benefit from it. And these are also geriatric patients. But I do see here that there was a missed opportunity to perhaps use the model to look at predicting the cognitive side effects of ECT, which is something that the patients are concerned about and limits them entering and benefiting from treatment. But if we look at the more common treatment, the SSRI treatment, there are a few studies. They've used different models, including the BrainHR, to look at escitalopram and sertraline. And here they don't show associations apart from the very large EMBARK study, showing that older-looking brains, so to say, benefit less from this SSRI treatment. But where are the other studies? We have a lot of these cohorts available to us already, and a lot of these models are in Docker or open source available. So I had access to one of our older studies looking at escitalopram treatment over 12 weeks. Here, 100 patients and a few controls. They were approximately 27 years old before treatment. And when we look at the brain age gap as expected on group average, the depressed patients look older than expected, and the health controls, the university students across the road, they look younger as expected. But what happens when we give them treatment? What about the patients who look slightly older than expected brain-wise? Who benefits from what? So when we look at week 8, like the usual studies do, we do not see a benefit or an association with treatment outcome. But when we look beyond this at week 12, because the thing is that when time goes on, you see a clear signal. Some patients fluctuate in their symptoms, so the true non-responders become more clear at week 12. We can actually see here the opposite of EMBARK, that higher brain age is associated with a greater benefit from SSRI treatment. So this is in slight contrast, but if we run the BrainAge R to compare with EMBARK, we actually see the same directionality that they found, although non-significant. And if we use the open source Enigma model as well, we can see a directionality similar to PyMint, although non-significant. Now, can BrainAge stand alone? No, perhaps we actually need to add them together or group them. And of course, people are more than their BrainAge. They exist in an environment and have a lot of other salient features we can use to predict with. And more data is needed. So as a clinician, I see that BrainAge is just another potentially useful metric to guide us in treatment selection together with the many other salient features. But on a closing note, while we think of the different models we can use and the multiverse perspective of repeating our analyses with different pipelines, it's also worth considering when we look at treatment outcome that the many metrics we use, they capture an underlying concept of depression, but the symptoms that they measure don't necessarily overlap that well. And when we do see response on one measure, it's worth looking into, well, what symptoms are they actually reducing? Again, because the drugs and the patients might have differential responses, also present with quite a heterogeneous outcome. Some might only benefit mood-wise, while others have reduction of insomnia and anxiety, but not the mood itself. So it's just worth looking at that these scales have different symptoms that they measure over different time scales, and that symptoms themselves fluctuate. But when you ask patients what matters to them, apart from just improving their mood, it is their general psychosocial functioning. And specifically, the cognitive symptoms that persist beyond remission are worth looking at as treatment outcomes because this is what persists and is also limits their functioning and is a risk factor for relapse, not only in depression, but other disorders. And finally, that there's rarely a treatment that is without side effects. So it is also worthwhile to attempting to predict the side effects of different drugs, for example, the cognitive side effects of ECT and the very detrimental sexual side effects of SSRIs, which limit adherence. So in summary, mood disorders, like many of the other psychiatric disorders, appear to present with some degree of accelerated brain aging, but it's observed across disorders and isn't present in all patients. So potentially this captures the impact of depression, may be a treatment biomarker and a treatment target in itself. But right now we see with the few studies available to us quite differing outcomes, possibly because the different models are capturing different aspects of aging. So we need more thorough investigations. We need both controlled data and also more naturalistic data that can capture some of the phenotypes outside of the brain. And we need to remember to also look at the side effects of our treatments. So with that closing remark, I just want to give thanks to some of the colleagues that aren't here that have contributed to this study.